That's what I do in Dar El Fouad Hospital. I do intraoperative ultrasound evaluating. في حاجة؟ the cursor شغال. Okay. أعمله لحسن عشان ما يقلبش بس معايا. Okay. That's what I do. I evaluate after the surgeons finish their operation, before anastomosing the ducts. I put the probe, intraoperative probe, and I evaluate the portal vein, the hepatic artery, the hepatic veins anastomosis before I tell them everything is okay. So proceed with the biliary system. As you could see here, after they anastomose the hepatic artery, you see it down there. There's the hepatic artery, and below it is the portal vein. Again, the hepatic artery enclosed with a bulldog clamp here, and you could see the flow gushing out of this artery. Sometimes they anastomose the hepatic artery proper with the recipient artery, or even the left gastric. This one is the hepatic artery proper. Another example, before they do the anastomosis, they have to clean the adventitia. They dissect the adventitia from the surface of the artery to be anastomosed, because this artery is friable and it is a diseased artery. That's in the recipient side. And then they proceed with approximating both ends, the donor side and the recipient side with the donor side. This is the liver graft here. And you could see this kind of approximator, we call it a micro approximator clamp, where it approximates the donor with the recipient side, so the surgeon or the microsurgeon is able to do the anastomosis. Again, here the micro applicator here is performed. The surgeon finished the anastomosis, about 12 anastomoses to the artery, and you could see there is no discrepancy between the recipient side and the donor side, using very thin proline or ethylene threads or needles, about 8-0. Again, the artery, after they finish and they remove the clamps and the bulldogs and every forceps, and I start, that's my hand here, to evaluate that artery, the integrity of this artery, the flow of blood in this artery, because it is very important to be sure that this artery flow is continuous and within a normal spectrum. You could see the hepatic artery here, and you could see the portal vein running down. Now, the hepatic artery complications in 15 cases out of 165, that's 9%, from August 2001 to March 2008. Before microvascular, they used a loop to do that, and the complications of strictures were very high, and even thrombosis were very high. That's 4 out of 28 cases, 14.2%. No signal detected by ultrasound. The management in 3 cases was reopening the patient again and repeating the anastomosis. 1 case we did an angiography and balloon angioplasty. After using the microscopy or the microvascular surgery, only 11 cases out of 137 cases, which was 8% complications. No signal in 8 cases. 1 case had hepatic artery stenosis. 2 cases showed dissection, yet remained patent. Management in 7 cases conservative, including 2 dissecting. 2 cases reopened and thrombectomy. 1 case reoccurred. 1 case angiography, another case balloon dilatation. Now, the hepatic artery complication, a liver donor, liver transplant, spasm is the most common, 30 to 40%, exactly immediately after surgery. Thrombosis, 4 to 12%, stenosis, 11%, dissection, 2%, and pseudoaneurysm and AV fistula are not common, but it happened in 1 case. Now, this is the normal appearance of the hepatic artery. You see anastomosis. That's the color flow. You see the post and the pre-anastomotic site. This is the anastomotic site here. You see the normal spectrum here, biphasic flow, peak systolic and end diastolic. The resistivity index is below 0.8, is 0.53, and this is optimal and perfect. Again, a little bit, this is a normal spectral flow with a little bit elevated upstroke of the systolic flow, lower diastolic flow, raised resistivity index due to a little spasm that happens for, say, 15 to 20 minutes post-surgery. Another example of normal hepatic artery, you see it, hepatopetal in red, the portal vein downwards. This is the fluid I put over the vessels to see both artery and vein simultaneously. You could see here the flow with the Doppler spectrum, a perfect spectrum for the hepatic artery. It means that the surgeon did a very good job, and they could proceed with the biliary anastomosis. Again, you could see the hepatic artery here. There is no turbulence, the uniform color, and there is the anastomotic site. An example of hepatic artery spasm, which is the most common, you could see here the upstroke of the hepatic artery and the downstroke with a low diastolic flow, and this is not good for a while. So what we do is, in this hepatic artery, we put xylocaine or lignocaine, or even we inject prostaglandin E to overcome this spasm. And you could see here the artery is improving from a very low diastolic to beginning good diastolic flow with a reasonably good resistivity index of 0.89. An example of hepatic artery thrombosis, this is intraoperative. It happened intraoperatively, and you could see the thrombus within the hepatic artery and after clearing up the thrombus. An example of thrombosing hepatic artery. Now you could see the hepatic artery here post-surgical, perfect hepatic artery with flow, perfect portal vein, again, portal vein bicolor Doppler and parangio, and you could see here the parvus tarsus sign. You could see this hours before it completely thrombosed. The parvus tarsus sign, or the tarsus parvus sometimes they say, is a thrombosing hepatic artery. When you see this, you have to tell the surgeon immediately, so either they do an angioplasty or a balloon angioplasty and thrombectomy, either open or by angiography, and do a CT. You could see here completely thrombosed hepatic artery running here, and that's the portal vein. Again, a thrombosing hepatic artery with a parvus tarsus sign, a very low resistivity index reaching 0.36. It means that artery is thrombosic. We have to salvage this artery quickly. Another example of hepatic artery thrombosis, no flow signal, could you see it in the hepatic artery, and you see here the portal vein below it. An example of the first case we did in Dar al-Fuad Hospital, and it was done with a loop, and you could see their complications here, very tight stricture at the anastomotic site. This is the portal vein down here, and an upstroke reaching over 2 meters post-anastomotic jet. And this artery was reopened, and the anastomosis was repeated again with a microsurgeon. An example of stricture, you could see here the stricture in the anastomotic site using the proline. You could see here again the stricture at the anastomotic site, and a very high peak systolic velocity with a very low diastolic velocity, and this is the incidence of thrombosing artery in this artery is very high. An example of hemodynamically significant anastomotic stricture, you see how tight that stricture is and how high the peak systolic post-anastomotic site is. It reaches 2.7 meters. It means 270 centimeters per second. This artery has to be repeated again using the microsurgery. This is the section. You could see the intimal flap here. It happened during surgery. You could see it here in another case. But the flow is patent, and they left it. They didn't do anything about it because the flow was okay in the recipient side. An example of the typical intraoperative dissection waveform, you see the double hump sign between the false lumen and the true lumen. An example of post-biopsy AV fistula, you could see the fistula here. This is the hepatic artery, and this is the portal vein, and this is intraoperative, and you could see the pulse, a pulsatile portal vein reflecting the anastomosis between the hepatic artery and the portal vein. Now, hepatic artery waveform in acute rejection, this is very peculiar and very sensitive. You could see this 2-3 days even when the start of rejection occurs. Even before the tacrolimus rises, you could see the hepatic artery coincides with the portal vein pulsatile flow, which goes down all the way to the baseline. Again here, hepatic artery and portal vein going side by side due to the microcirculation opening between the portal circulation and hepatic arterial circulation. The graft hemodynamics changes associated with acute rejection, sharp reduction of graft portal venous flow. You could see it dropping, say, from 30 to 40 centimeters per second down to 10 centimeters per second. Increased peak systolic velocity of graft hepatic artery fluid due to the inflammation, active inflammation cyanosis and acidosis within this graft. Changes of the portal vein waveform from stationary, parabolic, uniform to pulsatile portal vein. Changes of hepatic vein pulsatile waveform spectrum into monophasic or biphasic flow. Now finally, Finally, of all vascular complications, those involving the hepatic artery are the most serious, with retransplantation required. In as many as 75% of these patients experience hepatic artery thrombosis. Early detection of hepatic artery stenosis or thrombosis allows early revascularization and possibility of graft salvage within 48 hours, not more than that. Thank you very much. If there is any questions, that's the last presentation, so you have all the time to ask before the second session.
Yes, I have a question for you, Dr. Hussein.
Yeah.
Yes, thank you for your presentation. It's a very nice presentation. Even with the two clamps for the artery, maybe this is the commonest, but there are another types for anastomosis or another techniques for the anastomosis, but what you presented the most complex. My question about if there is a stenosis in the early post-operative, I mean in the first week, and the patient developed some disturbance in the transamine acid, then it returns to normal values. Do you intervene for this stenosis or not? The exact time you prefer to go for, and if you are going for, you just dilate or you put a stent also?
Well, actually, we have a baseline. When you do an operative procedure, LDLT, we have a baseline to start with. So we could monitor this patient every 12 hours by, in the intensive care by abdominal ultrasound, conventional abdominal ultrasound and color Doppler, to see if there is any alteration in the spectral flow and flow analysis, coupled with the tacrolimus level, coupled with the liver functions. So if there is acidosis going on peaking, tacrolimus is rising, there is disturbance in the hepatic function, we have to be careful in monitoring this artery. If we monitor it every 12 hours, we make it 6 hours, sometimes 3 hours. And I had my colleagues with me helping me in doing that to monitor this patient closely. If I didn't find any pulse, so we call it a pulseless liver, we cannot get a hepatic artery, we cannot reach it. So this has to be intervened not by surgery first. We have to do a CT to confirm that this artery is thrombosed or thrombosic. If we get the parvus tardus, this is an indication. He has to go to surgery directly. A thrombosing hepatic artery is very critical. We cannot do an angiography at the time, so we have to reopen him in the first 24 to 48 hours to salvage this graft. Portal vein thrombosis is not as critical, as serious as the hepatic artery, because it's the only oxygenating vessel perfusing the liver. So this liver is very sensitive to oxygen, and if there is depletion in oxygen, this graft will be lost. But if there is depletion in the portal flow, it's not important. He could survive, and this liver could survive for days and days until we think of something of embolectomy of the portal vein. But not in the first 48 hours. You could postpone it to 1 week or 10 days, unless it's completely thrombosed. The second most serious is occlusion of the hepatic vein. The occlusion of the hepatic vein, if it's one vein, it is, say, 50% serious. If the two veins are occluded, this liver will go. So he has to be reopened again, and it is more difficult. We will lose this patient sometimes, and not only the graft. So hepatic artery is number one. We have to consider it carefully. Any alterations based on the first examination, we always monitor with the first. And we see if there is alterations of the hepatic artery coupled with the laboratory tests. So this is the predictive examination or monitoring this patient, how to predict that there's something is going on, cooking down there, or it will happen in the future, in the near future.
Okay, thank you.
Any other?
Yes, please, Prof. Thank you for the nice session, very enlightening. I'm having just a question about acute rejection. So, yeah, what is your cutoff point for the peak systolic velocity in the hepatic artery? Do you have a fixed figure? Because sometimes when your resistive index is preserved, then does it have a value, a cutoff value?
No, it hasn't. It's not specific. But the only thing you would see is, say, for instance, if the baseline was peak systolic velocity was 40 centimeters per second, all the liver enzymes are high still post-operatively, and then they're declining, they're going down. Be careful of one thing. If this liver is failing you will have a declining liver enzymes. You'll think that this patient is getting better, although he's not. This liver is failing. That's why it doesn't produce any enzymes from the start. SGOT, SGPT is going down, gamma GT is going down because this liver is failing. So a lot of doctors, a lot of physicians fall into this mistake and this dilemma. Is that falling down because the patient is improving or not? No, the peak systolic velocity is not specific, it's not sensitive for rejection because he might have overflow, blood overflow because overperfusion. For instance, he must have some inflammation in the liver, any kind of inflammation due to secondary infection, so the peak systolic will rise. For instance, after he's on IV, but after he starts to eat postprandial, the mesenteric flow will increase and the portal flow will increase on the expenses of the hepatic artery. So the portal vein will increase. It would reach 30 or 40 centimeters per second because he already ate. And the hepatic artery, because it's a hemodynamic, it's a balanced situation between the artery flow and the portal vein flow. But if you see it peaked from 40 to 80, 90 centimeters per second, and the resistivity index going from normal 0.56, 0.6 to 0.9 or 0.8, there is something cooking here, and it might be inflammation, it might be acute rejection. You cannot know the difference. Oh, that's another problem. Either you will increase the immunosuppressants or you increase the antibiotics. This is very difficult, and it's on the head of the physicians and of the intensive care team.
Yes, thank you.
Discriminating rejection from infection. That's a big task. Yeah. Okay.
Thank you very much. If there is any question or comment from the audience, please. If not, I have to thank you all, chairpersons, speakers, and audience. Thank you very much to close the session. Thank you.